And a couple housekeeping items before I do turn it over. You do have the chat box available for any questions or comments that you may have throughout the webinar. Because it is through the Event Center platform, you will not have the ability to unmute yourself. So make sure that when you submit those questions via the chat, at a minimum, please send them to all panelists. It'd be nice if you could share them with all participants so that everyone could see what those questions are being asked. They may have additional questions based on what your ask is. One thing, please don't do unless it's a technical issue or something like that. Don't just send your questions to the host. That comes to me, and I can probably make up some really good answers for you, but I think our experts will do a little bit better job giving you the right answer. And with that said, I am going to turn it over to Rhea and Lucas to introduce themselves and get this started.
Thank you, Heike. Good morning, everybody. My name is Rhea Evans, and I am the Statewide Risk Prevention Coordinator. I'm also a licensed behavior analyst. With me, I have Lucas Evans, and I'll let him introduce himself.
Good morning, everyone. I'm Lucas Evans. I am also a licensed behavior analyst, and I am the Central Area Behavior Analyst for DB.
Heike covered our housekeeping wonderfully for us. Again, just use the chat box if you have any questions, and make sure you send it to all of the panelists for those of you that are just joining. So today we're really going to talk about learning your role when it comes to psychotropic medications and ways you can help the person receive the care that they need and learn of things that you could be doing to better help the treatment team and medical doctors know what's going on.
Okay, so let's start from a spot of why this is an important topic. And before I talk about why it's an important topic, let me just give a quick disclaimer. Rhiannon and I are not medical doctors. We don't even pretend to play one on TV. So this isn't medication prescribing advice. This is just information about psychotropic medications in the context of residential supports. Though, even though Rhiannon and I are not medical doctors, we have worked in a forensic psych hospital for a number of years, working with individuals with developmental disabilities and mental health concerns, taking lots of medications. And we also routinely consult on cases that involve medication. So we have some knowledge of the use of medication in this population. Again, we're not medical doctors, so just want to make that quick disclaimer. So let's talk about why is taking psych meds risky. So the first thing to note is that we aren't saying that people should never take psych meds. That's not what this is about. But we are saying that when you take psych meds, you invite some additional risk. That could be in regards to long-term side effects. It could be short-term side effects. So there's lots of health things that go along with using psychotropic medication. So some of those are like some of the ones that are most easily visible when you have seen someone who's overused psych meds is kind of uncontrollable tremors or shaking, sometimes called extrapyramidal symptoms. That's a serious side effect of using some antipsychotic medications. Other things you may not connect, like metabolic issues, so people gaining a lot of weight. Another thing that can happen, and we'll talk more about side effects a little bit later, but I'm just saying, so there's lots of medical side effects for taking medications. The other thing that is true is that the common recommendation from psychiatrists is that monotherapy is desirable. So using one med, if that's effective, is the most prudent course of treatment. Again, we're not medical doctors, but the literature supports the use of one medication. Sometimes there are benefits to using additional medications, and that's really up to the psychiatrist. But one of the things that is clear is that anytime you're adding more and more medication, more and more psychotropic medication, you're increasing those risks. And so one of the big dangers of what's called polypharmacy, or lots of meds, is that you're getting all of these kind of risk side effects or outcomes compounded and made even worse. So it's not uncommon for people that take a lot of psych meds to actually have a significantly shorter lifespan. So they tend to die earlier. They tend to be significantly overweight. They tend to have lots of other medical issues that are contributable or related to the use of the psych meds. So there are some risks. So the use of psych meds, again, is not something we're saying don't do, but there definitely needs to be a cost benefit done to determine if this is the least risky, least restrictive thing to do. And then the last part about restrictiveness is if people are taking medication and they don't want to, then we have to recognize that we may be limiting their right to choose, because maybe they need the medication, but if we have if we're kind of putting them in a position where they're taking it really against what they wish, then we also need to recognize that we're limiting their rights to choose, and we need to follow the relevant processes that are in place for when we limit people's rights, so just due process. So anyway, I've talked enough, but that's the gist of why psych meds are risky.
So just real quickly, I wanted to overview what psychotropic medications are. So typically we think of things like antipsychotics, anti-anxiety medications, mood stabilizers, antidepressants, sedatives, stimulants or non-stimulants. But really the point we want to make is that anytime medication is used to change behavior, we consider it psychotropic. So it could include over-the-counter medications, things like Benadryl to help calm a person down or help them sleep, things like cough medicine, some nasal sprays even. So really, if it's used to change behavior, that's what makes it psychotropic medication in our discussion today.
So here's a list of common reasons that psych meds are prescribed. Some of these have kind of already been touched on, but insomnia, so you can't sleep, so you take something to fall asleep. You can't concentrate, so you take something to help you focus. You're really irritable, so you take something to calm you down. You are really sad, or you're crying a whole bunch, and so you take something to pick you up. You can't get motivated. Maybe you're depressed, and so you take something to kind of help you become more active. Maybe you're having, or a person is having suicidal thoughts. They take some medicine. People have poor memory or concentration. Their moods are all over the place, or they are hurting themselves or other people. Those are common reasons why things get prescribed.
So the problem with those common reasons Lucas talked about is it's really hard to know what that looks like. And so we need to really figure out what actions are occurring. What is the person doing specifically that leads to medication prescription? Everything Lucas talked about are big old categories, and we need to narrow it down to what's the specific behavior. How would I know what's happening if I saw it? So if I was a stranger observing Lucas's anxiety for the first time, how would I figure out that Lucas has anxiety? It looks different for everybody. So is he pulling his hair? Is he pacing? Is he talking really quickly? Or is he going on the internet most of the day? Anxiety can look different for anybody. So we need to make sure that we're looking at observable and measurable behavior that's defined in a way that anybody could go and observe that.
In addition to thinking about what are the correlated behaviors or related behavior that's happening that helps us know about that mental health concern. We also need to recognize what are some common side effects the medication has. These range from annoying to uncomfortable to life-threatening. And so anytime we're taking any medications, we need to be aware of side effects that could happen, but specifically for psychotropic medications. So one of the things could be swallowing or choking issues. Hold on, we had a comment from Matt. He says, anxiety can manifest itself as anger or aggression. It's important to get to the root cause of the behavior correct. Well, I would say so my personal opinion is that the root cause is likely something happening in the environment around the person. I think that we have lots of ways that we describe mental health concerns. Let's take anxiety for one. I think the most important piece is figuring out what it looks like for that person, because that's how you communicate it and that's how you can determine if it's getting better or not. But I would definitely support that you want to figure out what the reason for the challenge is and address the reason. So I would agree with that. And then Kane, I'll get to your question in a second. Okay, so swallowing and choking issues are important. So sometimes medications will increase the amount of drooling that people have. And if it also makes them very lethargic or kind of sedates them a little bit and they're drooling a lot, you can choke, you can aspirate. Those are common concerns with some medications, specifically if the dosage is too high. Dizziness is another one, so balance problems, or specifically when you're getting up from sitting, which could be related to a blood pressure issue, or it just could be the medication makes your vision blurry. Could make you have sleep problems, so you may sleep too much, you may not sleep enough. You may get constipated, and this is one of those things that can be extremely life-threatening. So one of the major concerns with the use of psych medication is that it can cause you to become not just constipated or kind of make your bowel sluggish, but it can actually cause something called an impaction or an obstruction, which means that your bowels are no longer moving. And if that's not treated immediately, people will die. I actually personally have worked with people that have died from constipation as a side effect from psych medications. It's incredibly important that we understand that people's bowels are moving. And I know it's not the best, most comfortable conversation to have, but it definitely is an important one. Everybody needs to poop. We need to do that so they don't die. Mood instability is another thing. So medication can make people's moods go up and down. One of the things you might be detecting as you read these side effects is some of these side effects are the same sorts of reasons that people get psych meds in the first place. So sometimes psych meds can actually make you have more mental health concerns as a side effect. Memory problems, it can make you forgetful, can make you agitated. It can make you less hungry or less likely to eat, so you don't have an appetite. It might do the opposite and make you have a voracious appetite, and you may eat too much. It may make you have dry mouth, which in addition to being uncomfortable is related to lots of dental issues. If you have a dry mouth, it can cause your stomach to feel upset and to be nauseous and have headaches. So there's lots of side effects. And one of the reasons sometimes that people end up on polypharmacy is they start taking a psych med. It helps with one issue but causes another. So then they get another psych med to take care of the new issue, which in turn causes another one and another and another. And now you've got 4, 5, 6 different psychotropic medications that are being taken. And most of them are just trying to counteract side effects from the others. Okay, so Kana asks, aren't medications meant to incapacitate a person, a chemical restraint, and not allowed? Great question. So medications, and please refer to the official definition, which can be found in a door that we can link to everybody in the FAQ that comes out after this, but there's a specific definition for chemical restraint. But yes, if somebody becomes incapacitated after the medication is administered, that's typically considered a chemical restraint. And those are allowable under very specific circumstances. Please see 9 CSR 45 3.090 for the things that have to happen in order to use a chemical restraint. They are prohibited unless pre-approved, and there's a lot of stuff that goes with using those things. We typically would not recommend using a chemical restraint. And the other thing, too, is even if you're not intending to chemically restrain somebody, if they become incapacitated after they take the med, you have chemically restrained them, and that's why, you know, all the things that we're going to talk about are so important, and the communication is so important so that you can get those medications adjusted. So as an example, Ativan is a common benzodiazepam medication that people take for anxiety, and for some people it has a really strong reaction and makes them almost catatonic or very, very sleepy, and that would be could be an example if it does that to them, that would be a chemical restraint. Nakena added, so like Benadryl to be used to make a person go to sleep. So that's hard. So you have to think about what the reason the medication is being used. So if a doctor says, hey, I know you've complained about having trouble sleeping. If you take a Benadryl before bed, it'll help you sleep. Well, then the purpose of the medication is to help the person sleep, and that's not necessarily a chemical restraint. It's about the reason for the medication. So if the purpose is to help people sleep, then taking the medication and having the person go to sleep would be the intended effect. So it's important to think about what's the reason. And we'll get into the other ones because I don't want to keep holding up the talk, but we'll get to, there's a lot of good questions coming in. Okay, sorry, Ree.
No, these are all great, great questions. So just to make sure we hit on common side effects is really sometimes we don't recognize the side effects, and so we think meds aren't working, or we end up adding more meds, like Lucas said, to address the new problems that are occurring. And that's how we often end up with folks that are on multiple psychotropic medications, which increases their risk. So now we're going to talk about really what's your scope as a residential provider, so knowing your role. At the beginning, you're going to be gathering information, gathering data about what's going on, about those specific behaviors that are happening, so that you can give that data to the doctor so that they might better know what medication is needed, if medication is needed. You're going to make sure that the meds are taken as prescribed. You're going to take data to track, like continue taking data to track those specific behaviors to see if they're getting better, are they getting worse, are new behaviors or side effects occurring. And you're also going to track when the meds are taken. And then you're going to share that data with the doctor, with the behavior analyst, with other team members, so that everybody has the information they need to know big picture what's going on.
So what kind of data do you need? Well, you need to know when you gave the meds, and hopefully that lines up to when the window for when they should be taken. And then a quick note on taking medication. So if a person refuses to take meds, we're not saying that you should hold them down and make them take it. You should be taking data about what they refused and when they refused it, and then taking that back to the treatment team, to the planning team, whoever it is that is working on these issues, to together figure out a way to figure out either the reason why the person doesn't want to take the meds, because there might be a really good reason. We just went through a whole bunch of really bad side effects that they might be experiencing, or there may be something else that can be done to arrange a situation that the person's more likely to follow their medical treatment. You want to know what behavior is happening both before and after, because before is probably related to why the behavior or why the medicine's being prescribed, specifically if it's an as needed or a PRN medication. But you also want to know what's happening afterwards. So if the medication is a PRN med that's been prescribed to deal with agitation, and agitated looks like high-pitched, really pushed speech, the person, pacing really quickly back and forth while they're shaking their fists in the air, and then you give that medication when that's happening and that never stops, well, that's good information to know, because that means that the PRN is not having the desired effect. Or, on the other hand, if the person becomes so slow, they're drooling and they can't stand up straight, and they can't keep their mouth closed and their tongue is protruding from their mouth, well, then those are other things that you also need to take data on so that you can convey that back to the physician that, yeah, the agitation's gone, but now we've got a whole bunch of other really concerning things that are happening. And so that would give the physician more information to help him or her figure out what the most effective dosage is. And again, we're not doctors. We would want to know, and you should want to know, what other things are happening around the person. Are they continuing to engage in their daily life as they had before? Are they isolating away from everyone? Are they eating or sleeping more than normal or less than normal? Have they started having weird kind of obsessive tics or obsessions over certain things? So just anything that's different. Those are all the kinds of data that you would want to know, both prior to going to the doctor for to talk about medication, and also after medication is on board, so that you can make sure that you know that the behavior associated for the reason for the med is actually improving, so that you know the medication's working, and also so that you can detect any of those problematic side effects that come up, so that you can make sure the doctor knows how the person's actually doing.
So we just want to really make sure repetition's key to memory. So we want to make sure we repeat over and over that it's more than just taking the data. You've got to share the data with all team members. So the medical provider, the behavior analyst, anyone really working to help the person be more successful. So share that data with all members involved in care, and do it regularly and frequently.
So I'm going to quickly go through a few things that we think might help, and then we'll kind of take a little bit deeper dive into each one of these in turn. So safety crisis plans. If you weren't expecting that to be on there, then now you've seen it. We always talk about them. They're really helpful and often required when dealing with behavioral challenges. Skills teaching. We're going to keep talking about data because that's the only way we know if anything's working or not working. And then communication. So those are the four areas that we think would help. And we're going to go through each one in turn.
So again, we've talked lots about safety crisis plans, so I won't go too in depth for it. A lot of you were on our previous webinar, but just in case you weren't, a safety crisis plan is a tool to really help staff know what exactly they need to do, how they need to respond when certain behaviors are happening. So specific to meds, this might mean that you should include in the safety crisis plan whenever something like a PRN medication should be given or offered. And then also, what's the plan if meds are refused? That should be included in the safety crisis plan. And we've linked the resources again here. It will be available for you when the webinar is posted.
And one last note about safety crisis plans. So another thing specifically about PRN medications that's really important, and this is something the doctor can help you figure out, is there's a certain time period that happens after a person ingests the medication before it starts to take effect. And that's really important to consider when you determine what's the most beneficial place in the crisis cycle that medication should be applied. And so even though medication shouldn't be our first line of defense, we should have other things that we're working on, and I'm going to talk about some of those on this slide. But if it's a medication that is been prescribed that could be helpful in those moments, and it takes 30 minutes to take effect, you don't want to wait all the way until the person is punching holes in the wall and beating people up before you give it, because now it's probably too late. The other thing is sometimes when people are escalated at a certain point, the medication doesn't bring them down that much. And so being able to catch it early, and again, this is where the data is important about kind of how things escalate. And this is when the doctor can use that information to determine when is how much in advance does that as needed medication need to be given in order to have the best benefit for the person, to help them maintain control and to continue to have the meaningful day that they presumably want. The other thing that you should be working on as part of any ISP that a person would have in our system is a set of skills that address the needs that that the team has determined during their needs assessment. And there was a really good question from Kathy that I purposely saved to this part, because she asked any suggestions on how to help consumers accurately report bowel movements for monitoring constipation. And so that might be one of the skills. So the first thing to think about is what is currently the barrier for them communicating it? Is it because they struggle to communicate in general? Is it because they don't want to talk about it because it's embarrassing? Those are two separate things that you would do. So if they just struggle to communicate in general, well, then one of the things that you should be working on generally is increasing their communication. There are lots of ways to help people communicate more effectively. One could be just to teach them to talk. Sometimes people haven't had the opportunity to learn how to have typical verbal language. There's also devices called augmented communication devices, which can be helpful to help people that aren't able to develop regular verbal language as typical. And so essentially it's just a tablet or some sort of electronic device that has buttons or cards that can be touched on the screen that are related to words, and people can use those to communicate their wants and needs. You could go super old school, which you did before there were tablets and electronic devices, and you could use something called PECS, which is just a picture version of that augmented device where you're just handing cards or pointing to things on a piece of paper. Sign language is another thing. There are lots of ways that people can communicate. If you are supporting a person that has no communication, that should be your primary concern, is how to help them communicate better. Not only because it would increase their quality of life tremendously to be able to actually communicate with other people, it'll also help you identify what is the reason for any problem they may be experiencing. One of the most common reasons for challenging behavior are medical reasons, and if a person can't communicate to you that they're having a medical problem, you're creating a recipe for them to suffer and for them to continue to medically decline while we try to do some sort of behavioral strategies that probably aren't relevant. The other thing that might be true is that they don't want to tell other people because it's embarrassing. One thing that you could do in those circumstances is, one, recognize that it is embarrassing to talk to other people about your bowel movements, and think about where you're having those conversations. Is it in the middle of the living room with the other housemate? And where would be a more appropriate place to have it? So if, let's say, the person can write, just leave a notebook in the bathroom and they can just kind of record what they did in there. You could also have one of those, I think they're called a Bristol Myers stool chart, which kind of has little illustrations of different types of stool. Again, this isn't the best conversation or most fun conversation to ever have to have. It's just really important. But if you could get one of those laminated with a dry erase marker, they could just kind of mark what happened. And so long as you have reason to think that that's pretty accurate, so they're not saying everything's all good and their belly looks really distended, or you you aren't hearing kind of the discomfort or grunting from the bathroom that would indicate that maybe that's not working so well, then that's fine. Kathy asked a really good follow-up question is, what if they're changing their response? Well, you know, I don't know. It could be. So here's one thing to ask, to find out is, do they really know how to describe what kind of bowel movement that they had? So, you know, if you say, is everything moving okay? Like, do they even know what that means? Or if you say, are you constipated? Do they know what that means? So again, that Bristol stool chart might help them be able to connect what a typical or normal or a healthy bowel movement looks like versus what a non-healthy, non-typical one. So that might be some education that the nurse can provide. Other skills that might be important that aren't related to bowel movement, hooray, could be just general social skills. So if somebody is struggling with social anxiety, so they have a hard time talking to other people, building up their social skills can help them feel more confident and competent, being able to talk to other people, being able to do something to help them calm down. So we all get in those situations where something happens and we get really mad, and we even say things like, I can feel my blood pressure just going through the roof. Like, what sort of things can we do and other people do to help bring their pulse down, bring their blood pressure down? It could be deep breathing, it could be walking away, it could be listening to music. So there's lots of skills that people could learn that would address the reasons for the medication, help them cope through uncomfortable situations, and just generally have a good quality of life to the best of their ability. And if you are thinking to yourself, well, gosh, I don't know how to teach those, that's great, because we have services that a person can receive to help work specifically on those things. And we'll talk a little bit more about those in a minute, but there are people out there that can help you and the person acquire these skills. And last but not least, if somebody's doing something that they should be, that's desirable, that is skillful, so that moment that typically would have made them get really upset and break something and they didn't, make sure you recognize that. Make sure that when they are acting effectively and appropriately, that we're making sure that that pays off and they recognize that they did a good thing and they know that we know that they did a good thing. Because a lot of times what happens is, you know, we only notice things when they don't happen, and then we call attention to them not happening, and we don't recognize when people are spending most of their time doing pretty well throughout the day, even if it's just nothing particularly significant about what's happening, just that things are going normal. That would be something to recognize for somebody who has some significant troubles. So making sure that you recognize the skillful things that people are doing on a day-to-day basis, because even folks that struggle the most are probably still spending 80% of their day doing just fine. And we just need to make sure we recognize those times.
All right, so just to recap, I want to note that psychotropic medication by itself typically is not enough to help the person reach their full potential, is how I'll word it. So teaching those replacement skills are really, really important to help the person know ways that they can behave differently. So like Lucas talked about, if Lucas pulls out his hair right before he has to talk to a certain person, and now he's got these bald patches because he just keeps ripping his hair out, teaching him some ways he can talk to the person and maybe prepping for conversations ahead of time might help him be more skillful when he does have to talk to someone that he would normally rip his hair out if he had to speak to them. So teaching those replacement skills is probably the most important thing you could be doing. And again, I'm going to be a parrot and say data, 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 because like Lucas said, we won't know whether things are working, whether they're getting better or worse, if we don't have the data to support that. So we need to be looking at are meds being taken as prescribed? Are they being refused? Is the behavior for which they're prescribed getting better? Is it failing to get better? So if the behavior is getting worse, or you're seeing lots of side effects that might make it seem like the behavior is getting worse, medications should be reevaluated by the doctor to see what else might be tried.
So here's a list of some other services that could be helpful. And just to kind of hit these really briefly, but we do have a consultative service that we offer residential and non-residential service providers called tiered supports. And that is a service for your whole agency that will help you set up the systems to, among other things, take data and to help ensure staff know how to do the daily things that they're supposed to do, and that they're taking the data the way that they're supposed to do, and that you're also recognized when they do well. And so it's a way to supervise and manage staff, help you set up systems to take the data, maybe even help you with how you communicate that data to other people. And it's just generally some consultation to help you help your whole agency be more effective in the supports that they provide to individuals with developmental disabilities. There's also technology supports. So this might, for somebody with mental health concerns, it could be, do you have a counselor or a social worker or somebody that you could have a phone call with quickly, like when you're in a really particular rough patch and the person needs to talk to somebody, and they make, I've heard them called coaching calls, of being able to reach out to find somebody with expertise really quickly. Hopefully it's somebody that they've already been working with could be helpful. If you are needing to do some additional monitoring, there's also some technological stuff that could help with that, so that you can help support people become more independent, but also continuing to provide any kind of necessary oversight that they might need while they demonstrate success without somebody specifically in the room with them. Community integration is a service that can help teach skills related to being out and about in the community. Behavior services, or applied behavior analysis services, is a service that can help teach really any skill. And this is where, if a person doesn't know how to communicate or is struggling with lots of daily living skills or responses to do instead of hurting people or hurting themselves or breaking things, this can be a really helpful service to teach those skills that meet the needs that they have. Other services that aren't on here related to communication specifically, but speech language pathologists are also really good services to help people with communication. Behavior Support Review Committee is a place to get help if you are a team helping a person and you're really stuck with a really challenging situation that just keeps happening, or you just can't find a way to get past it. That's the place to go to get some free consultation. It's made up of behavior analysts that provide services to community members or other members in the DD system, and they volunteer their time each month to come in and give free consultation. It's chaired by one of the behavior team members. There's also employment services. Employment services can be very helpful, not just because it helps teach people, skills that help them earn money, but it also is one of the most common places that people socialize. So if you think about your life, thinking about my life right now, most of the places that I have my social interactions are workplaces, especially now with everything closed down. So giving people, helping people get a job isn't just helping them to earn money and to be independent that way, but it's also helping them to have typical places where they talk to other people, and also having to develop the social skills to thrive in those situations as well. Counseling is a great service to help people with mental health concerns, and would be, I would think, mandatory to go along with any sort of psych medication that's being prescribed for a mental health diagnosis. One of the things that seems to be true is that people who get psychotherapy and medication do better than people that just get medication. And people that use or continue to have help developing skills live better lives and are overall more healthy over time. And one of the reasons for that is because as people become more skillful and learn more skills and get these community supports in place, they don't need to rely on the medication as much, and that allows for medication to be either discontinued or to be kind of titrated down to the lowest effective dose, which minimizes the amount of side effects the person has. And also, being socially connected to other people is one of those things that helps people live a good long life. I do have one caveat with counseling, just so everybody is aware, and this has been sent out, I believe, through the DD Blast, but pretty soon counseling will no longer be a service in the waiver. It doesn't mean that people still can't get counseling. They still can. Counseling is still covered under state plan, so they can get it through straight Medicaid. It will not be in the waiver shortly. I think March 2021 is the month and year in which it will no longer be in the waiver. The other thing that is important is medical evaluation. So sometimes people have mental health-like concerns because they have an ongoing medical problem. So a common example of this is thyroid problems that seem to present as anxiety, inability to sleep, inability to concentrate. Other things could be like urinary tract infections being related to irritability. No wonder you're in extreme pain, but also things like what people would describe as psychotic episodes. So people becoming kind of detached from reality related to serious urinary tract infections or just infections altogether. Other things that you might consider as well is sometimes when people take medication to treat medical problems like infections and antibiotics, they also develop some sort of side effects that are behavioral in nature, so irritability and all those sorts of things. So having somebody who's medically following a person is always a really good thing, just in general, but specifically whenever there's psychotropic medications or mental health concerns or behavioral concerns happening.
I wanted to get a shout out to a previous training that Melissa Witherspoon did. It's a recorded webinar on monitoring psychotropic medication. So we talked a lot about taking data around psych meds, and I think her webinar goes into more detail about how you can take good data and monitor the use of psychotropic medications, and that's recorded already on our website. And then we have some upcoming opportunities for everybody to learn more about this subject and other things. And so we've linked additional webinars, some virtual workshops, and then the provider support committee where residential providers can come together, and it's really like a learning community. We'll have a theme each time and an open discussion around the theme. Lucas, were you going to say something?
No, you covered it. I was just going to remind people that when they get access to these slides, that there are links throughout the document that will take them to the resources that we're talking about. So if you were worried that you didn't know where all these things were, don't worry, links are in there. Okay,
Ruth asks, wouldn't you agree that medical conditions should be ruled out first before psychotropics are prescribed? Lucas, I don't know how you feel about this, but I agree that yes, we should always rule out medical conditions before anything else.
Yes, I would agree with that as well. So we should always be thinking about what medical conditions could be causing what we're seeing, and we should be addressing those first in the ideal world. And if what's happening is serious enough and there has to be, so like a psychiatrist feels like he or she has to prescribe some medication right away, or there are a significant need for behavioral strategies, I think those things should happen too, but we should continue to work on figuring out what the medical problem is. So sometimes it's, ideally it's medical first, then everything else, but sometimes it needs to be medical while you do some kind of preventative things. So for example, there are lots of behavioral things that you can do in the short term while you're ruling out medical problems, like removing excessive amounts of demands in the person's life, just generally increasing kind of the good things that are happening and the amount of what we call reinforcement or good outcomes for non-contingently. So they're not having to work to earn good things. You're just trying to make them comfortable in their life pretty good while you try to figure out what medical things are happening for them. In the same way that, if you are having a lot of anxiety and you've got a thyroid problem and the doctor's saying, well, I've given you what I think is the right dosage of replacement hormone, but it's going to take 3 weeks to 3 months before that hormone level comes up to what it's at. So I'm going to prescribe you some anxiety medication for you to take short term while that hormone comes up. And then after that hormone is at the normal level, you shouldn't need it anymore. So all those things are considerations, but yes, definitely addressing medical things first or as quickly as possible. And not just at the beginning of treatment, but if some drastic change happens with a person, the first thing we should always think is medically what's going on. So if all of a sudden somebody who's doing okay just completely decompensates or things just kind of go downhill really quickly and now they're doing things that look crazy or they just stopped eating or they started sleeping all the time, the first thing that we should think of is medically what could be going on that could account for this, and then move on to other things. Ruth asked another great question. How long does it really take to determine that a medication is working or not working before you try something else or try something in addition? That is a great question. So I'm going to give you my opinion, and then I would recommend that you talk to a doctor. Again, it depends on the medication. So each medication has a particular period of time where the dosage gets to whatever level that's quote unquote therapeutic in the bloodstream. I'm not a doctor, so that's as much detail as I want to share on that. So it really depends on the medication. So the key thing is talking with the doctor about and asking that question specifically. That's one of your roles, is to ask the doctor, how long should I expect until I see some improvement? So at what point should I know that the medication is working? He might say a week. He might say several months. That's really dependent on the medication and also how the person metabolizes the medication. So that's really going to depend on the medication, and I would recommend that people talk to doctors about that.
I want to add too, because Ruth's question also mentions in addition, that my professional opinion is that psychotropic medications shouldn't be used alone. So we should be working on those skill building behaviors that we talked about. And so what replacement behaviors should be happening. And so there should always be something in addition to the psychotropic medication.
There was also a good question about experience using GeneSight, which is a genetic testing that is supposed to help doctors determine which psych meds are least likely or most likely to be helpful for a person based on their genetics. In talking with some psychiatrists, a lot of what I hear is that the data is just there's not enough data really to say whether it is or isn't helpful thing to do. Some people think that it has been really helpful for them, and some people say that there's just not enough research to support that it's effective. So again, I would leave that up to psychiatrists. If they've used it and had good success with it, I think that's great. I don't want to provide any more of an opinion on it because it's just, again, it's be outside of my scope as a professional. But it is something that happens. It is a common thing that people are doing. And if the psychiatrist believes it to be effective and they've had some good success with it, then it seems reasonable.
All right, I'm looking through the chat box. I think we covered all of your questions. If anybody else has any questions to ask, please send those to all of the panelists. And now's the time for us to answer anything you've got. There was one question asking, how will you guys get this? This will be sent out via email, whatever email you provided when you logged into the webinar, and then it will also be posted on the division's previous webinar page with links to all of the resources we discussed. And I just want to say thank you, everyone, for joining us today. I know mornings are kind of hard to jump on trainings like this, so we really appreciate you taking the time to come and listen to us and ask questions. And it looks like we have a question from Matt asking, what efforts are being made towards collaborative care with analysts and psychiatrists? So one of the big efforts of collaboration, and Lucas, feel free to add to this, is sharing of data. So again, behavior analysts are really good at knowing what data to take when it comes to those reasons for which meds are prescribed, and then seeing if the medication has an effect on that behavior. And so sharing that data with the psychiatrist, and then the psychiatrist sharing when meds have been changed. That's a big key towards that collaborative care you talk about, Matt.
I would add to that. So there are multiple prongs of things that we've been trying to do over the last several years to help this area. So one of the ways that we've tried to help is specifically related to behavior analysts and how they provide treatment. So if you look at the behavior support CSR that is in effect now, which again is 9 CSR 45 3.090, you'll find a section in there that describes all the things that need to be in a behavior support plan. So that's the treatment document that the behavior analyst completes to help the person address the reason for their problem behavior. And you'll actually find that one of the things that the behavior support plan has to do is have a way to track data for behavior related to the reason for psychotropic medication. So we're working with behavior analysts to recognize that they need to be concerned about medications, because it's actually part of our ethical compliance code that says that we have to be concerned about anything in the environment that affects a person's behavior, and medication is specifically being prescribed to affect people's behavior, so we have to be concerned about that. And so we have to take data on it. That's part of a comprehensive behavior support plan. We don't have to be doctors. We shouldn't be making prescribing decisions, but we should be paying attention to the things that affect people's behavior, and medication is one of those. Another thing that we've been doing is we actually have created a professional organization called the Missouri Alliance for the Dually Diagnosed, or co-occurring diagnosis, or multiple diagnosis. But it's a professional association that includes multiple disciplines, so behavior analysis, psychology, social work, counseling, psychiatry, medical doctors, really just everyone, advocates for individuals with co-occurring diagnoses, to come together and create learning communities where these various groups can get together, meet each other, find out that each side is also just like them, a regular person, and they can communicate and start to build those networks and build rapport with one another, work together to get training and problem solve challenging cases. And then we've also launched a task force, actually. Mark Stringer, the director of DMA, launched it a little over a year ago to come together, all of these various groups of folks, and come together and define some best practice standards for the treatment of people with co-occurring mental health concerns and developmental disabilities. And we actually have a treatment manual, treatment recommendation guide, and an app for clinicians to help them think about all of the considerations, one of which is medication. And so we are working very hard to help people recognize their responsibilities with collaborating and how to collaborate and what things to think about to be better collaborators. Matt, when the app goes live, it will be free for everybody to access. It's not currently accessible to anybody right now because it's currently being built and it's in testing. But once it's live, it will be freely available for everyone. It's primarily targeted for clinicians right now, but it's not secret. Everybody can see it. There's some more questions. I'm sorry, I'm trying to weed through them. Ruth asked, do you discuss medications that are not recommended for persons with IDD and DD? Again, we're not doctors. People should talk to psychiatrists, specifically psychiatrists that have experience prescribing and treating mental health concerns in people that have intellectual and developmental disabilities. One of the things that seems to be true is that medications that are effective for typical populations don't necessarily have the same sorts of effects in populations that have developmental disabilities or that are children. And then when you have people that are children and have developmental disabilities, then it gets even more wonky. So again, looking to the psychiatrist with that experience to provide that information. I will say that there are a few medications that have some empirical support specifically for certain developmental disabilities like autism spectrum disorder and the use of risperidone as an adjunct to help with some agitated behavior. Again, not a doctor, just can read a research study like anybody else. So those are the things that I would ask the psychiatrist about. Let's see if I missed one. What about pharmacogenetic testing? Why isn't the department promoting this? Again, we're not promoting it. So I don't have any other better answer than that. So there's some mixed professional opinions about pharmacogenetic testing on whether or not it's effective or not. I'll leave it to the professionals, not me, to determine whether that's a good thing or not. But I know some psychiatrists use it and have found success with it. I know some psychiatrists avoid it because they don't feel like the empirical base is strong enough to use it yet.
All right, it looks like we've covered all of the questions, and it is 9:57, so thank you all for joining us, and we'll be hosting the next Tier 2 risk prevention webinar next Tuesday at 9 a.m., so we hope to see you there.
Thank you, everyone.